Hi, this is Brian Kim. I'm going to share with you case number 257 in the Best Way to Do Cataract Surgery series. And the title of this series, again, is not to suggest this is the best way, but to get you to think critically of your technique, to refine and hone your technique so that you can provide the very best for your patient. So this is a moderate cataract density lens. This is also a toric lens. I want to try to place it at the 167 axis, but you'll see it's having a hard time to rotate. So I'm going to use a two-handed Toric IOL rotation technique, and hopefully this will provide you some tips on how you can deal with a similar situation. So you can see nice dilation, nice retraction of the eyelids. You can see my marks that I made while the patient was sitting upright. I'm using the cotton tip to steady the eye, and this is a corneal marker which will help me to center and size the rhexis. I make my paracentesis incision first on the right side, and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I always use a cotton tip to help steady the eye when I make those incisions. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. I use the cannula and twist it within the incision, which is called the Orlock technique. You can tell this is the left eye of the patient. And then I make my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And I'm using that cannula to hold the eye in the neutral position using the Orlock technique. These are the microrhexis forceps. I puncture the center, pull down towards me, and then I grab the right side of the tear, and I'm trying to make sure I make the rhexis about the size and centration of the corneal mark that I made previously. And again, I'm using that cannula with the Orlock technique to keep the eye in the neutral position because this patient has a little bit of a Bell's reflex, again, in this left eye. Finish off the rhexis, burp some viscoelastic out, place some viscoelastic on the corneal surface. By doing this, my assistant doesn't have to keep putting fluid on the cornea. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, do a little bit of a jiggle, get a nice wave, lift the lens up. By lifting the lens up, you can more effectively decompress the bag. And then you can see the lens begins to spin. I always lift the lens and then decompress. This has increased my ability to spin the lens after hydrodissection. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Leading with the chopper, again, it's slightly pronated. I'm leading with the chopper tip, it's pointed down. By being pointed down, I'm able to slide it under the rhexis edge. As I slide it out, I turn vertical and I'm hooking the peripheral lens. The phaco tip is stabbing the lens subincisionally. And now I have essentially flanked the lens with the instruments, the endonucleus, bringing the instruments together, and I'm able to crush and divide the endonucleus. Pronating my hand and sliding the chopper again somewhat flat, leading with the tip. I'm sliding the tip under the rhexis edge contra-incisionally around the right heminucleus, drop it into the capsule fornix. I have the phaco tip already deep. I pull the chopper centrally towards the phaco tip, and I'm able to bisect the right heminucleus. Again, the phaco tip is acting like a chopping block. Placing the chopper around that first quadrant and pulling that lens piece up, crushing it with mechanical forces, and then emulsifying the lens piece. Turning the second quadrant in front of me, grabbing it with some vacuum, lifting it up, crushing it with mechanical forces, and then emulsifying it. Turning the second heminucleus in front of me, placing the chopper under the rhexis edge contra-incisionally. The phaco tip is deep. I'm able to fracture the lens in half, grab the third quadrant with some vacuum, and then crushing it with opposing forces, and then emulsifying it. Grabbing the last quadrant with some vacuum, crushing the lens with the instruments, and then emulsifying it. So again, very efficient lens disassembly, minimize CDE, protecting the cornea, maximizing mechanical fracturing, minimizing risk. Go ahead and remove the epinuclear material now. You can see a great control, great chamber control. And I always make sure that chopper is deep to the phaco tip when I'm removing these last pieces. So I take the chopper out, push BSS in, take the phaco tip out, and I'll go in with the INA handpiece. Always start sub-incisionally. You see the sleeve is a little bit retracted too much. I'll adjust the sleeve now. Start sub-incisionally, peeling side to side, sweeping side to side to get bigger sheets removed. Always try to remove the cortex from anterior to posterior for a cleaner peeling of the cortex. Switching to polish mode, polishing under the rexus edge to remove the lens epithelial cells. Polishing the posterior capsule as well. Pulsing BSS into the subincisional capsule fornix, which was clean. Disengaging the fluid and then pushing cohesive viscoelastic to fill the bag. Polishing with a sweeper under the rexus edge, first on the left side and then the right side, removing some more of that lens epithelial cells. And I like the sweeper because it gives me better access to the subincisional area, the subincisional capsule fornix. But as you can tell, nice big pupil. Not a terribly dense lens now looking at it, but again, efficient lens disassembly with double chop and cross chop and mechanical fracturing techniques. Placing the toric lens into the capsular bag. Again, I want to position it at about 167 degrees. Placing the lens within the bag, go in with irrigation off, activate irrigation, disengaging the haptics off the optic, getting underneath the lens, removing all the viscoelastic from within the bag, polishing under the rexus edge. And whenever I do the toric alignment, I always go to lower mag. I think that helps me really see the eye in the macro perspective, which is better for aligning. And so I picked wrong. I had it rotated a little bit counterclockwise to 180, but I have to turn it more clockwise. So I'm turning it over to try to get to the 167. And as long as infusion is on, you can go ahead and rotate it like this. There used to be from the companies this whole concept and notion of you can only rotate the lens clockwise and not counterclockwise, and that is absolutely 100% not true. As long as the bag is completely inflated, you can rotate it either way. But what you don't want to do is try to rotate it with the eye completely collapsed without infusion. So this is a Maltzman, and I was able to, with infusion on, rotate the lens in the proper location, using the axis ring to verify its position. Removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had, not a terribly dense lens, kind of a standard density of lens. You saw double chop, cross chop, mechanical fracturing techniques and concepts. Once I put the lens in, I had to align the axis, and I used the Maltzman, again, with infusion on. I was able to nudge the edge of the lens at the optic-haptic junction distally, and I was able to rotate that lens clockwise and align it at the 167 degree axis. Again, as long as the eye is inflated, you can use a second instrument and reposition the lens in whichever way you want with a second instrument, and it's completely safe doing it that way. Again, never try to align the lens when the eye is completely deflated. If you try to rotate the lens when it's not actively being infused with the INA handpiece, you're really looking for trouble because you might rip zonules, and you probably aren't actually moving the lens whatsoever. You're just nudging on the capsular bag and the zonules. So always inflate and then reposition, and you should always be good to go. So I hope this was helpful to you, and I thank you for your attention.